Okay, we're going to go ahead and get started. I'm Dan Bailey. I'm a physicist at Northside Hospital Cancer Institute focused in Atlanta. And this is Ellen Herron. She's our lead therapist at the Alpharetta location. And I'll show you a map in just a second to kind of get you oriented to where we are. Hopefully this is a very practical talk about the way in which we handled the initial motivation for commissioning an SGRT solution, how we branched out from special treatments to using it on everybody, and then eventually at one of our clinics went to completely marker-less treatment, and kind of showing you the roadmap from where we started and how we got there. So improving treatment safety and efficiency with SGRT for all treatment sites. And we'll talk for about 25 or 30 minutes and then let you guys ask us questions so we get to hit the stuff that you're most interested in. Just a few acknowledgments. Northside Hospital Cancer Institute does share reference site agreements with both Varian and Vision RT. Alan and I don't have any financial benefit from those reference site agreements whatsoever. And Northside Hospital Cancer Institute is actually a lot more complicated than this somewhat dated slide shows. But so that you get an idea, our main campus, our Atlanta campus, is on the very north point of Atlanta, just inside the 285 perimeter. Ellen's clinic is in Alpharetta, about 10 miles north. Forsyth Clinic is about another 15 miles north of that. And then my home base is to the west in Cherokee. And across those four clinics, we have 10 Varian Linux, which include 4 TrueBeams. We have 4 Align RT systems that all have the SRS module with the 3 degrees of freedom head adjuster. 3 of those units have the motion management interface that I'll talk about a little bit more in a minute. We have a Gamma Knife Perfection at our Forsyth location, 3 HDR suites, and a really busy LDR program for prostate seeds and ocular melanoma IPLEX. So you're at an SGRT meeting, so you already know everything that's on this slide. I don't know why I've done it 3 times, and now I'm doing it a 4th time again. I guess I don't learn. I'm a typical physicist. So we're moving beyond CCTV, monitoring of the patient, which is so very qualitative, to try to quantitatively track patient positioning to the millimeter or even sub-millimeter accuracy level. And we're doing that via real-time, non-radiographic localization and positioning via visible or infrared tracking of an external surface contour. The refresh rate is several times a second, so it's close enough to be called real-time monitoring. And again, very importantly, it doesn't introduce any more imaging dose, so no more ionizing radiation to the patient. The general motivations for building an SGRT program at your clinic are to reduce interfraction positional variability. So this is the positional variability from day to day, from fraction to fraction with a particular patient as you set them up again and again. To mitigate, because it can't be completely eliminated, intrafraction positional variability. So this is for things like respiratory motion or small patient movements that maybe in a normal conventional fractionation setting are not that important, but in a stereotactic setting can be, very, very significant. To allow for precise geometric reproducibility, especially for difficult setups and special treatment setups like deep inspiration, breath hold. And to facilitate faster setup and treatment times. Now remember that when we talk about safety, when we talk about setups and treatment times, typically your mind goes to throughput, which is definitely true because those are inherently, linked. But really, the more time the patient spends in the room on the table, the more opportunity there is to move, the more opportunity there is for other things to go wrong, and everything kind of gets exacerbated. So facilitating faster setup and treatment times is really a safety and quality issue as much as it is a throughput issue. That's general reasons. To get a little bit more focused on why Northside wanted to implement an SGRT solution, we had a couple of physicians who were absolutely adamant that we needed a better deep inspiration breath hold solution. When I arrived at Northside in 2013, we had this older system with an optically tracked jig and a little video game monitor thing that the patients had to watch, and it was total junk. It wasn't reliable. The software and the hardware both had multiple issues to the point that it had really been dormant and unused for a number of years, and that's pretty unacceptable to not have an accurate, reliable deep inspiration breath hold solution, particularly for left breast patients and particularly for young left breast patients. We also had at least one physician who was very enthusiastic about real-time monitoring in order to implement a frameless, mask-based LINAC stereotactic solution. So intracranial SRS treatments on a LINAC without a frame. And we were all absolutely adamant, physics, therapy, dosimetry, physicians alike, that we had to have some kind of accurate real-time monitoring system if we were even going to think about moving toward having that as an option for the clinically appropriate cases. And thirdly, of course, improving setup time and reproducibility, especially for difficult anatomies. These are those cases where you take pictures, you know, there's a roll, you don't know exactly how much you need to roll them, you go in the room, you do the best you can, you come out of the room, you take pictures again, you go back in the room, you chase the rolls some more, and you end up doing so many images and so much time spent going in and out of the room. Having some way, you know, to mitigate those kind of scenarios, to have more accurate, more efficient setups, particularly for difficult cases. So I'm going to throw these three things up on the board here, and we're going to hang out here for just a second before we hand it over to Ellen, and she's going to talk about some of the lessons that we learned during the course of this process. But since 2014, we've treated hundreds of patients using Align RT, and several conclusions have been cemented for us through both positive and negative experiences. Number one, patients move way more and way more often than we ever knew before. So in other words, gone are the peaceful days when we thought we took a cone beam CT and the patient stayed that way throughout the course of treatment. Because really quickly we learned as soon as we turned on Align RT that that was totally not true. And in some scenarios, they can move in a way that you don't see on the TV monitoring, right? That are actually very clinically significant, and I'll give you an example of that in just a minute. Secondly, we learned over the course of about 6 months, we proved this to ourselves, that camera-based SGRT has the potential for exceptional geometric accuracy, not just in phantom, but in patient. I was the first one to say, this cannot possibly be true. I was at a phenomenal clinic in the Northeast through my training and residency, in which all of our intracranial stereotactic was with Gamma Knife, and I was convinced, without really looking at the data, that there was no way that a LINAC-based solution could compare. And so for about 6 months, we took cone beam CT, of course, immediately before we beamed on, at which point we capture a reference image with Align RT. We monitored the patient using SGRT throughout the course of treatment, sometimes having to stop and recone beam in the process. And then at the end of every treatment, we took a post-treatment cone beam CT to try to collect the data that we needed to test whether or not the SGRT system was really telling us a direct, accurate comparison to what cone beam would say, as a physician, of course, was judging the patient's location based on cone beam. We don't have the data to present to you. Hopefully, we're going to wrap this up into a peer-reviewed publication relatively soon. But for the purposes of this talk, just let me, suffice to say that I was absolutely gobsmacked by the ability of SGRT to corroborate really for cone beam to corroborate what Align RT was telling us. So that just every single time, with every single scan in patient, at least in an intracranial setting, that's the limit of our data collection for this particular project. They were absolutely dead on. And thirdly, that leads to this very important point, that the advances in safety and treatment accuracy that you can make with SGRT, they're phenomenal. They're more accurate and more efficient than probably we've ever had the capability of before, but that safety and that treatment accuracy are highly dependent on the quality of the training that's received by every single user. And I don't really just mean training, I really mean learning, because your training can be amazing, right? And our training was amazing. And yet, you can't absorb everything you need to know during training. There's unique things that happen in your clinic that are not touched on in training. There's issues that arise that you could not have foreseen while you had the vendor there in training. And if every single user, from dosimetry to physics to therapy, to some extent the physicians, are not completely trained in how exactly the system works, you can actually make your patients less safe than they were without SGRT. And I can give you an example of that. Here's a nice little anecdote. So there was a SBRT situation in which we had a patient with very poor mobility. He was very difficult to set up, and he had a really hard time holding his arms in location. So it's one of these nightmare cases. The patient's been on the table for like 40 minutes, 45 minutes. Finally, the physician gets to the machine, approves the CBCT, and it's time to treat. We're ready to treat. And a line RT says that the patient has moved by like 5 millimeters or something longitudinally. Nobody wants to cone beam again, right? And at that point, this SGRT thing was relatively new to us. And one very well-intentioned therapist said, well, why don't we just take a new reference image?
It was not me.
It was not Ellen. Because if you take a new reference image, everything goes away, right? Everything turns green. Everything goes to zero. And we have at this location the motion management interface that if the patient is not within tolerance for a certain amount of time, you can't beam on. There's no way around it. So, of course, we can't take a new reference image. We took a new cone beam, and you can expect what the outcome was, because it wouldn't be a very good example if it wasn't true. The Align RT was telling the truth. The patient had moved. And what he had actually done was he just moved his arm a little. That's all he did, because it was uncomfortable for him to stay in the immobilization device. And we could not tell. You could not tell looking at the TV screen that he moved. And yet cone beam said that there was a 6 millimeter longitudinal shift, which in stereotactic terms, how big is 6 millimeters, right? We're talking about a football field. And to try to impress that upon American football, I don't know how big a soccer field is. So, are they the same? Anyway, so to kind of impress that on the treatment team, I took the map check QA. You know map check? It's the little diode planar array, right, that we use to do QA. So we basically take a planar measurement of dose and compare that to a treatment plan, you know, at the same reference conditions to try to compare how accurately the machine is delivering that treatment within, you know, the assumptions and approximations that you make with reference conditions. And when you do the accurate delivery, at least at the lenient, you know, criteria that we use of 3% 3 millimeter, the pass rate for the accurate delivery is like 100%. But if you shift your measurement, the same measurement, by 6 millimeters, then your pass rate is like 27%, okay? Just trying, there's a little bit of mathematical trickery going on there, but just trying to, you know, get the treatment team thinking about what we're talking about when Align RT is telling you that there is a shift. You're well-commissioned, well-QA'd, properly trained team that you need to believe what it's saying, okay? Which leads me to my one funny slide. Are you ready? I was only allowed one. They gave me a quota this time because I joke around so much in my talks. As Master Yoda would say, if you end your training now, if you choose the quick and easy path as Vader did, you will become an agent of evil.
I think Yoda would say,
an agent of evil you will become.
You will become. Fine. Listen, this is my slide. Okay, so I'll turn it over to Ellen for lessons learned. Thanks very much.
Okay, so I'm just going to go over a few initial lessons we learned that are kind of interesting after using SGRT. And one of those is SGRT has you thinking a totally different way as far as therapy goes, such as immobilization. Typically, we would use immobilization to actually encase the body part we're treating, have it come up high on each side of the leg or wherever we're treating to make sure that patient is limited within their movement. With the ability to track and monitor the patient in real time, it's not necessarily needed. It's more of a need to focus on an open surface area so your cameras can actually read a good ROI. And we found as long as the patient is comfortable and stable, that the machine will tell you, obviously, if they move. So another thing we learned, and this was just kind of a bonus once we started thinking out of the box a little, is that we have more information than ever at the machine with this DICOM image. So obviously, every clinic has vac locks that deflate or masks that get lost. We've actually learned that you can use that initial DICOM image to reset this patient up in the treatment room and make a new device for the patient. So we use open face mask at our clinic. So as an example for that, we would have the patient lying on the table. We'd pull up their DICOM image, hit play, make sure we got that patient in the correct DICOM position. And when they were in that position, we would make a new mask over them. As it was drying, we would make sure they maintained that position and then confirm with cone beam and doctor's approval. So what that does is eliminate the need to resimulate, replan, re-QA, and most importantly, there's no delay in the patient's treatment. So initially, we started using the system mainly for DIBH patients, and we determined very quickly that these patients need to be checked at CT to make sure they're actually a good candidate for DIBH treatment. So it's a lot easier to tell that at CT rather than to have them planned in the DIBH position and then figure that out with the machine and then have them replan. So we have the RPM system at our center, and we make sure they can do a few consistent breaths in to achieve that DIBH position. Initially, we also used to set up our patients using marks to their free breathe position and then try to get them in the DIBH position from the marks. And that did not work well for us at all, which makes sense now. We're saying those marks are not as accurate and not as precise as a free breathe reference would be. So trying to match not as precise marks up to a precise DIBH position did not always work well. Another thing we learned was you would have to just create a separate reference capture for things like bolus fields.
Oh. So we don't want to go into stereotactic all that much, but just kind of piggybacking on that point that Ellen made about DIBH, learning that using the free breathe setup and SGRT is a more accurate and efficient means of setting the patient up than triangulation using marks. We found the same thing for setting up our intracranial stereotactic patients as well, and a lot of this was actually advice that we got from the faculty at UCSD, where before we would just click the mask into place and then go outside the room and take a cone beam. Rather, using the real-time data that you have right there at your fingertips to get the pitch, roll, and yaw translations as accurate as you can before you ever exit the room, right? Before you ever make any adjustments with your 3 degrees of freedom head adjuster, so that then you reduce the amount of images that you have to take because you're closer to the right position before you ever put the mask on. But also, I don't know how much experience you have using the 3 degrees of freedom head adjuster. A lot of places have the 6 degrees of freedom couch, which we don't yet, but you have a limited range in the amount that you can adjust that patient in those rotations. So if you aren't pretty darn close to where you need to be, then you're going to have to make rotations that are too big in magnitude for this to there's a word I'm looking for, I don't know what it is, to do, okay? So, and anyway, that's not a very elegant word, is it? So, accommodate, I think that's the word I was looking for. So anyway, using the SGRT system smartly, maximizing its use to set up your SRS patients better.
So our center is now markerless, and we've been that way for about 2 years, but it was a process to get to that point. And some of our motivation, we were actually, as therapists, the biggest skeptics at first, until we actually had a trainer come back after we had basic training. They came back a couple months later to give us advice on more advanced training. And once we actually saw the system actually worked and it was actually a great tool for us, we were the ones who actually pushed to go to a markerless clinic. So one of the motivations for that was the patient satisfaction. This offers a worry-free treatment for the patient. They can focus on their rest and healing instead of keeping their marks. They can continue with their hobbies, swimming, stuff like that. And then it's also an alternative for patients who are allergic to adhesive or their religion prevents them from getting permanent tattoos. We also noticed efficiency increased using SGRT, and a lot of that I think has to do with the therapist being able to see the patient's movement in real time. So we actually use table parameters as an initial setup for these patients and then tweak to align RT. But when it needs that tweaking, the therapists know exactly what to do. There's no talking over the patient. And we actually realized that we had been over-moving these patients with marks compared to SGRT. The system proved its accuracy to us, and because of that, it reduced our need for repeat imaging in a lot of cases. As the senior therapist at my center, what I love about this is the consistency of it, that every patient is set up the same way, that there's no confusion, there's no multiple marks to know which mark to go to, no color-coded marks, no shift sheets, some patients get set to SSDs and some don't. Every patient is set up the exact same way, and the therapists walk in that room and they're confident they know how to set that patient up. And then we started using this on DIBH and SGRT patients, which are more complex cases. And if we can use on those cases, then we should be using for our simplest cases and maximize the use of this technology on every patient. So to get to that point of being markerless, we had to go through some issues. If things arose, what would we do? One of the things we realized was indexing every single patient would be very beneficial to us. Because they're indexed to the table, we actually could tighten our couch tolerances. And that's important because we use these table parameters as that initial setup to get the patient into treatment position every day. Another thing we could encounter was transferring patients. We're not actually attached to a hospital, so if our patient went to the hospital and needed to be treated inpatient, what would we do? Luckily for us, every center within our system has at least one Align RT system. So that patient would be transferred to the machine with Align RT. And then as far as software and system issues, it's rare we have any issues. Most minor issues can be fixed by restarting the cameras and computers. If we were down for an extended period of time, we would send our DIBH and SGRT elsewhere. And then the remaining patients we would set up using their table parameters, cone beam CT, and doctor's approval. So to prove our point to management and people that weren't using this SGRT on a daily basis, we agreed to collect some data. So we had a 3-month trial period where we collected data on every single one of our patients. We treated them, we collected the data on using marks for the first half of the treatment and then using SGRT only for the second part of their treatment. And then as we did this, we reduced variables as much as possible by using the same 2 therapists to set up every day.
We had pretty frequent follow-up meetings during that 3-month period of time, which included therapy, dosimetry, physics, nursing, and admin, basically showing progress, showing issues that we've had, closing those feedback loops of those questions and showing how we're trying to mitigate some of those questions. So, things don't get, questions get left out in the air, which is not a good way to implement any system ever. And then, of course, at the end of the 3-month period, to actually analyze the data that we collected. So looking at these quantitative metrics of how much time was spent in the room, magnitude of shifts based on IGRT, imaging frequency, measured SSDs and how they deviated from the planned SSDs, and basically ways that we could concretely compare marker setup versus SGRT setup to produce some results. So one of the first things that we learned, can we go to the next slide? Was that, as we expected, the time setting up and the total in-room time was reduced via SGRT. I'm going to show you a graph of this in just a second, but one important thing is to realize when you look at that graph that not only was the total time reduced, but also the variability in the time spent in the room was reduced. In other words, time was more consistent. Because there's those cases, and sometimes it's just a particular day with a particular patient, that for whatever reason you're having a really hard time setting that patient up, and a minute turns into 10 minutes, turns into 20 minutes. You're chasing around the the repositioning based on your IGRT, and with the real-time feedback that you get with SGRT and setting the patient up, and you're very close before you ever leave the room, those outliers basically disappear. So not only does the time shrink, but the consistency gets much better. The average shift magnitudes, this is of course based on checking the patient's position via the gold standard of IGRT. Average shift magnitudes made having set the patient up with markers were much larger than the average shifts that were made setting the patient up with SGRT. And also the SSD deviations between actual SSD and planned SSD were less setting up with SGRT than with with marker-based, which is what we expected, because you do the best you can do with what you have at the time, which is the way that I tell myself I can sleep at night now that I know that I've treated patients for 12 years before I ever had SGRT, and I don't know what I did to those people, that you say we did the absolute best that we could at that period of time with what we had, but now we have better. Setting up, yeah, we do the best we can, lining up 3 little skin markers to lasers. You do the best that you can, reading the SSD on an ODI, right, an optical distance indicator. But the fact is that we're just able to do it better with SGRT. So you can't see the numbers here. This data is actually in an Astro poster from last year, so you can look it up and look up the write-up, and we're working on getting it into a manuscript form. But this is just for breast treatments. And we're comparing setup time with marker-based setup versus SGRT setup, and imaging shifts with the marker-based setup versus the SGRT setup, SSDs for the markers and SSDs for the SGRT. And basically what you see is that for the normal setup, you've got you gain somewhere between 10 and 20% time gained by, that is less time spent in the room using SGRT, which is on the order of somewhere between 1 minute and 3 minutes per typical case. But a minute per case, if you've got 40 cases, is 40 minutes. And if you've got 2 minutes per case over the course of a day, now you've got 80 minutes less with the patient in the room, which is not just a throughput issue, but also a safety and efficiency issue. And of course, the imaging shifts and the imaging shifts were smaller, and the SSD differences were smaller. I don't have data for it in this talk, but the biggest change in time was actually for VSIM day. So on the first day, you see the patient that you set them up and you're going to do your dry run. This is typically where you're going to have those issues that you have to go outside the room, image a whole bunch of times before you finally get them into position. And in those scenarios, which I realize is typically only 1 day for most cases, or maybe 2 days for most cases, we're talking about upwards of 50% time saved by doing your VSIM based on SGRT setup versus marker-based setup. So a huge difference using AlignRT for VSIM day. And you put all that together, and basically what we conclude is that you have improved consistency even between rotating staff and PRN staff, less confusion based on markers and shift sheets, less time spent in the room, more accurate position initially leading to less imaging frequency, better intrafraction motion, which especially can be absolutely vital in stereotactic settings where tiny motions that you never would have seen before. Now we can actually quantify and know if we need to cease treatment and recomb beam, so that overall we can say, having received no financial kickback from an SGRT company at all, that we have been able to drastically improve both the safety and the efficiency of treatment for every patient by maximizing the use of SGRT. And that's basically our talk for today.